This is Jackie George. Jackie previously worked at the Ohio Department of Medicaid and was a huge resource to our folks that are in the DoDD system of understanding a lot of what was going on between ODM and the department and why we have to do things, everything EPSDT and all that stuff. So lucky for us, Jackie ended up transitioning to work for a company called Myers and Stauffer. And she has gone into a different kind of consulting company where they have actually helped Nebraska transition to the InterRAI in the last few years. Monica Yenger met her at, I think, NASD's at one time, and was when we were still just kind of getting there. We hadn't, for sure gone this way. And so Monica has stayed in contact with Jackie, and then I found out that she was there, and we said, oh, we don't know everything about how Ohio is going to go. We're still, a lot of you all know about as much as we all know, right? We're kind of working through the process. We are going with the InterRAI. But a lot of details are as you roll it out. And it's an evolving situation in each state that this happens, what exactly you use the tool for, and a lot of specifics. So Jackie is going to give us how her experience in Nebraska rolled through the implementation of InterRAI and what they learned, and some, probably challenges and some successes in that. So keep your questions so that at the end you can ask. Just remember, similar to the last session, this is a story from Nebraska. It will give us some good information about maybe some things that might happen, but it also might give us some more questions that we can think about as we're moving through this implementation and talk to the Department of DD about it. So, interesting fact, Jackie has had braces 3 times. 3 times. And she doesn't want to use the Invisalign that got left here recently. So remember, if anybody is missing Invisalign, I have it in a secure location. Come up after the session. All right, Jackie, I'm going to go ahead and turn it over to you.
Thanks, Lisa. Hopefully the mic is working. Yeah, looks like, okay, great. Thank you all for having me here today. It's such a pleasure to see some of you again. I am really, really privileged to be able to talk about the work that Myers and Stauffer did in Nebraska, and really thinking about how we can help Ohio learn from that experience, both good and bad. We have a really packed agenda today. I know I'm right before hospitality time. I always seem to be right before hospitality time, and people don't really love that.
Mic for you. I think this one's a little more powerful.
Awesome. But so again, I'm going to try to get you out of here as soon as I can. But again, we really do have some great information to share with you today. Really, I want to focus on the work that we did during our pilot period with Nebraska. But to really level set and provide some context, we will have to do some kind of background work to get us there. Today, our objectives are, as you can see on the screen, but again, it's really to provide a primer to the InterRAI suite, understand how it's used and how it has been validated, why standardized assessments are important in the work that we do, and really learn about, again, Nebraska's experience and maybe take away some items for you all to think about as Ohio moves forward with the InterRAI. Before I move forward, I'd like to give all of my caveats. Myers and Stauffer does not represent InterRAI. We just happen to like their tool. I do not speak on behalf of the state of Nebraska, nor do I speak on behalf of the state of Ohio. So this is just our experience, and we hope to be able to, again, share some wisdom with you all. As Lisa said, I joined Myers and Stauffer at the beginning of 2022. I was with the Ohio Department of Medicaid for 7 years. I actually started out as a data analyst with Medicaid and then moved on to a policy role where I served as the liaison to the Department of Developmental Disabilities. So I'm really familiar with your programs. I've been keeping up a little bit with some of the improvements, the changes that have been taking place over the last couple of years. With Myers, I do focus primarily on developmental disability programs, but I've actually been tiptoeing a little bit into the behavioral health space. So I am lead on 2 projects that are focused on the InterRAI implementation for behavioral health programs. One is actually in Nebraska, one is actually in Oregon. I'm doing some work in Kentucky right now on implementation with a new waiver program as well. So let's start with some background. You can see the state of Nebraska. Please disregard the lines coming from some of those counties. I did some fancy snip work with my tool, but it wasn't perfect. So the lines you could disregard. But this is the state of Nebraska. It's really important to note, and we'll talk about it a little bit later on, that Nebraska is divided into DD districts, kind of similar to our county board setup, but it's a little bit bigger as far as geography. Kind of like a cog setup is maybe the best way you can think about it. Nebraska has, I think, 93 counties, so similar in terms of numbers to Ohio. Douglas County is actually where Omaha sits, and then Lincoln County, it's actually in red underneath kind of that yellow area. That is where Lincoln is. Most of the state's population sits in a few really highly kind of urban areas, but urban is not the same thing in terms of Nebraska as it would be to us. Again, most people reside in Omaha, Lincoln, Kearney is another big area as well. When we get out to the western part of the state, it is very, very rural. In fact, I think it is true that there are more cattle in the state than there are people. And that's not to be, derogatory in any sense. It's just a fact. We're going to talk a little bit about some demographics a little bit later on as comparison. But again, for our context here, Nebraska is very small in comparison to what you in Ohio are thinking about. So when we start thinking about implementation, your implementation will almost by default look a lot different because we just have more people. These are just some stats. I think it's actually really interesting that the Medicaid population is roughly 418,000. They are a relatively recent expansion state. And as you can see, the expansion population is almost a quarter of all Medicaid enrollees, at least as of 2023. We'll actually come back to this slide in just a second, but this is just some data for you guys to think about. These are the 3 developmental disability waivers in Nebraska. I did some look actually this morning at the most recent waiver comparison chart that's published by ODM. And it looks like as of June of this year, IO was about 25,000 or so people enrolled. That's way more, as you can see, than the people who are enrolled in any of the 3 DD programs in Nebraska. And we'll talk a little bit about the waivers here in a moment, but the comprehensive developmental disability waiver, obviously the highest enrollment number in the state of Nebraska, that is sort of the equivalent to IO in that context. But I, again, kind of just wanted to note that, we have almost more people enrolled on IO as they do seniors enrolled on Medicaid. Not quite, but almost, right? So I think, again, when we're thinking about numbers, it is a very stark difference to Nebraska. Again, just some additional state comparisons for level setting. Obviously, our population is much higher. We in Ohio obviously have 3 kind of different departments that administer waivers that are at the cabinet level: Department of Developmental Disabilities, ODM, and then Department of Aging as well. In Nebraska, they're under a Health and Human Services system. So Health and Human Services is sort of that umbrella cabinet level agency. They have multiple divisions that sit under that. So the Division of Medicaid, the Division of Developmental Disabilities, Public Health sits under there, as well as does Children and Family Services, so like child welfare. It's just a slightly different structure than what we're used to here in the state, but similar in terms of responsibilities and tasks. Just a quick overview. So again, we took a look at some of the enrollment numbers for the 3 DD waivers in Nebraska. Again, CDD, or the Comprehensive Developmental Disability Waiver, is really the best equivalent to IO that Nebraska has. It includes the residential employment services, does include some self-direction to your last speaker. The DD80 waiver is really only for adults. It's pretty focused on employment supports, does offer some limited residential services, not kind of like a group home setting, but more of like an independent living setup, supports for families as well. The family support waiver, and you may have noticed on the previous slide that the enrollment was really, really low. That's for good reason. It's a relatively new waiver in the state. It was actually legislatively mandated, I believe in 2022 or 23. CMS actually just approved the waiver in March of 24, so it's had almost about 18 months of actual enrollment to date. They've had some difficulty actually enrolling folks. There's a number of reasons for that. But it is birth through 21. It does have a cap of $10,000 as the budget limit. And again, just some more enrollment numbers. I think you will have access to these slides, so this is kind of a nice handout. Just again, some quick features. I would say that, it is similar in terms of makeup, right? 3DD waivers across the states. Administratively, DD is obviously handling those DD waivers in Nebraska, just as DODD does, but the setup, the structure from a governmental perspective is slightly different. So let's talk about the InterRAI. So the InterRAI is really not just one tool. It's not just two tools. It is many tools. We call these a suite of tools that encompass not only developmental disability programming, behavioral health programming, covers individuals with complex medical needs who might be residing in a hospital. But it really is a vast array of tools that are focused on transitioning individuals in the continuum of care as their needs change. It is highly reliable and validated. It's been validated actually in a number of countries. It is web-based. And so what that means is InterRAI is implemented through like an electronic health record or case management system. So it's really accessible kind of regardless of where you are. The nice thing about InterRAI, and one of, I think, the best selling points of InterRAI is that it really is intended to support decision-making in a number of different spaces. And what I mean by that is we can think about it from a policy perspective and a clinical perspective. It's putting the person at the center of these conversations while incorporating the rest of their care team so that we are thinking about them in like a person-centered manner, but it can be also used, the data and the results can also be used to drive administrative decisions like budgeting, enrollment into waiver programs. I know Ohio is particularly interested in using it for budgets potentially. We'll talk about how Nebraska actually implemented it, but it's meant to do a variety of things. So in that way, it's really meant to be multi-purpose, right? And we'll talk more later on in this presentation about why Nebraska has chosen to use and adopt this tool, but primarily in order, I mean, not just to improve person-centered planning, but really it was meant to kind of eliminate duplication in their processes to save time. Once you save time, it provides better quality of care and case management to people. So really, there's a lot of benefit to the suite. In addition, it's modular, right? So it's not a questionnaire. You don't have to ask questions, and we don't like to call them questions, they're items, but you don't have to ask items in like a sequential manner. Depending on the conversation, and we really encourage assessors to be kind of organic in the way those conversations happen. You can jump around the assessment as much as you need to. We do ask that assessors rely on documentation to the extent available, particularly if individuals don't know the answer to certain questions, if the line of questioning is provoking potentially some trauma. So documentation can be used, but again, we really encourage assessors to use the individual as their primary source of information. What is actually really nice is that InterRAI as the organization does allow some customization. So they recommend no more than 5% customization. We typically see states adding questions that are specifically tied to their eligibility criteria. That's in like state regulation, a waiver application, state plan language, whatever the authority might be. For instance, we had some really specific questions that we ended up adding to the InterRAI community mental health assessment as part of our work in the Nebraska space in their new behavioral health program. So that is something that you can do. Again, it's not encouraged that states or another implementing entity kind of tweak the questions that InterRAI has developed because they are standardized. But again, if you need to add a question for some really specific reasons, that is okayed by the InterRAI organization. So thinking a little bit about this graphic, right? How does InterRAI enhance person-centered planning? Again, it's really robust in nature. And this might scare some of you, and it's not meant to, but there are easily 100 or more items on the InterRAI intellectual disability form. And again, it's not really meant to be duplicative or time-consuming for anybody involved. It's really trying to get at who is this person? Because people are not, and I don't mean this to be racial in any way, but people are not black and white. There's a lot of gray space. We are people. And we want to be able to capture that nuance with people. And so how does the InterRAI do that? Again, it has a lot of data that we're collecting. And the way that Nebraska used it, at least for eligibility, is we looked at all of those data points to make sure that we were thinking about multiple pathways to eligibility, because we don't want to have people become ineligible with the implementation of a new assessment. So again, those data points are really, really important. And because there are so many data points, in this way, it's pretty person-centered in a way that a lot of assessments aren't. Again, we really want to put the person at the center of these conversations. And the InterRAI does account for really diverse needs. It has multiple sections that are dedicated to physical healthcare needs, behavioral healthcare needs, informal supports that are available, residential or inpatient histories. I mean, it accounts for all of that in a way that some of our assessments today just don't. You'll see on the graphic a mention of CAPS. Depending on the assessment we're using in the InterRAI world, it is can mean various things, but today we're going to refer to it as clinical assessment protocols. We will talk about how those CAPS help inform person-centered planning after we talk about the pilot demonstration. So again, let's talk a little bit more specifically about Nebraska. This is how the Division of DD assessments worked, at least historically. So somebody would need to be found Medicaid eligible through the various channels that somebody can be found Medicaid eligible. It would then go to the eligibility and enrollment unit within the Division of Developmental Disabilities for a waiver eligibility decision. Now, Nebraska did historically have what they called a registry, what we would know as a wait list in Ohio, that it has since been expired through various efforts from the director of DD and the governor's office. So again, this is a little bit different than how it is working now versus how it was working historically. But historically, people would sit on that registry for a while, and then eventually their name was called and E&E would assess. Once an assessment took place and eligibility was determined for waivers, they would then move over to service coordinators, again, who sat with the Division of Developmental Disabilities. Service coordinators are SSAs in Ohio. So they were responsible for case management, ongoing monitoring, contacts, that sort of thing. In Nebraska, again, the three waivers we're talking about are all ICF-IID level of care waivers. Their criteria is pretty different, or at least it was historically, from what we know in Ohio to be ICF-IID level of care criteria. Each state is allowed to develop their own criteria. There is no federal standard for what that looks like. In Nebraska, they were using something called the developmental index to assess for level of care. Again, in the Ohio context, this is equivalent to the DDP. The DI was homegrown. It looked at a number of different domains, if you will, including the level of dependence and self-care, abilities in receptive and expressive language, learning, mobility, self-direction, capacity for independent living, social skills and traits, and abilities in economic self-sufficiency. When our team first started looking at developmental indices, or the DIs, we had a lot of questions about some of the questions they were including. For instance, under the learning domain, they had a question that read something to the effect of, do you know how to ride a bike? Riding a bike doesn't indicate a developmental disability. my husband doesn't know how to ride a bike, and he isn't diagnosed with a developmental disability. So we had a lot of concerns actually with the way they had been previously assessing, as just an example. Also in Nebraska, they have individual budget amounts, or IBAs. This is a little bit different than the budgets we are used to in Ohio. They are not geographically based. They are based on acuity or funding tiers, so you can see those acuities on the screen. They were using something called the Inventory for Client and Agency Planning, or the ICAP. The ICAP is, while standardized, extremely old. It was first developed in 1986, hasn't had an update, I think, since 1986. It still references a phone book. It doesn't really account for behaviors. So we heard a lot of complaints about the ICAP. Funny enough, Nebraska actually wasn't updating ICAPs yearly. So while they were using this to some extent for person-centered planning, we saw many ICAPs as part of our pilot that hadn't been updated in 5 years. And when we said, hey, do you know this is happening? They seemed not surprised, a little quizzical. They have since learned, oh, actually, we had a major problem that we weren't aware of. So they're correcting that now. But the ICAPs had a lot of problems. So thinking about some of the limitations with this historical assessment process, right? A lot of duplication. They have multiple assessments that they were using, and I didn't even touch on the assessments they were using to determine that somebody qualified for their DD services, okay? So a lot of duplication in that space. Information was siloed and split up across the division to some extent with Medicaid as well. Outdated assessments. Again, I just indicated that the DI and the ICAP, neither had received significant updates since they were really implemented, which is obviously a concern. And this assessment process was overly reliant on judgment, right? Many of the DI elements, as we found, did not have any sort of quantifiable output. It was really left up to an assessor's judgment as to whether or not somebody met the criteria. But the problem was there was no criteria to really evaluate. So how do we say that this is determining eligibility in an equitable way? Again, there was this over-reliance on judgment, and that really created some inconsistencies and potential disparities in eligibility as well. I will say that some of our work in Nebraska, we were doing a number of different things with the Division of Developmental Disabilities up until recently. But again, back in 2023, we conducted a system evaluation. This was sort of part and parcel with the legislation that actually required family support waiver be put in place. But we undertook this system-wide evaluation to think about what was problematic in the space. And it wasn't just waiver programs, it was anything DD touched. We did many different types of stakeholder outreach. We had 7 90-minute sessions with families, guardians, advocates. We had 2 90-minute provider sessions, 2 90-minute state staff sessions, 1 just open listening session for the general public. We engaged with the University of Nebraska, both their medical center and their USET as well. And then we solicited online feedback through a survey. We collected 241 responses as part of that. What we heard were concerns about assessments kind of holistically, not just the DI, but the ICAP. We found that families had a hard time navigating this complex web of waiver services, which I'm sure you're all familiar with as well. A lot of concerns about equity and timeliness to services, particularly because of the registry, but also just kind of access in general, and then trust and appropriateness. People really didn't trust that if I'm assessed by an E&E staff member and then have to move to service coordination, that the information was shared appropriately across team members. It also created a lot of differences in what people were being told. So just lack of trust, I think, was something that we heard throughout that stakeholder work. What we did here, we took some of the stakeholder feedback that we got as part of the DD system eval and tried to crosswalk it to InterRAI and how InterRAI as a assessment solution could address some of these concerns. So I'm not going to read all of these, but I do want to point out a few. So this Complex, confusing application process, not a clear point of entry for somebody who might be really unfamiliar with services. The InterRAI really is critical because it does support integration with case management systems. It can help streamline referrals and applications. It can, based off of results, kind of tell an assessor what a need might be so that we can direct people to the appropriate services. Thinking about equity, timeliness, and access. The one item that I do want to point out here is the delay in service receipt that requires kind of proactive intervention. Again, sometimes we do face these barriers like a wait list, a registry, but once we can enroll somebody, let's quickly give them services. Through InterRAI, again, it generates these, you'll see it's collaborative action plan here, also clinical assessment protocol, these caps that help inform person-centered planning. It can also generate acuity scales, which is, for instance, they take into account multiple different items from the InterRAI and scores it so we can see if somebody has a really high aggressive behavior that needs to be addressed, or maybe a really severe limitation in mobility that needs to be addressed. Let's talk about how to address that either through waiver services, Medicaid state plan services, maybe non-Medicaid funded services. It really kind of hones in on people's needs in a really informative way. Again, trust and appropriateness. I think about kind of what I hear across different states now, what I experienced in Ohio around eligibility, enrollment, and coordination. What is maybe the right waiver for me to enroll in? How, if my needs change, how does that change maybe my waiver placement today? Because InterRAI uses this suite of tools, it really can be used across different types of programs to make sure that there is continuity of care kind of regardless of the program. It shouldn't matter where you're enrolled. It really should matter if you're getting served. And this is kind of the end game here, right? And I will say too that with InterRAI, though there are many different types of tools, again, spanning developmental disabilities, medical complexities, behavioral health, many of the items included are actually very similar. So again, that does provide some level of continuity across assessments. In Nebraska, we really wanted to implement the InterRAI to address a number of different things. Primarily, they were concerned with waiver eligibility, and so wanted to focus on that piece, or the level of care piece. They also really wanted to think about how InterRAI could be leveraged for program enrollment in a different way than they had been doing previously. Again, there was a registry in place. People would sit on this registry for years and years and years, end up on the comprehensive DD program, regardless if that's really where their need was. They had a lot of children on the registry. And we heard a lot of, I don't really need a waiver. I need a waiver to get my kid Medicaid eligible, but I just need pharmacy services provided through Medicaid. So maybe the comprehensive DD waiver isn't the most appropriate place for that child to end up. Let's talk about a different waiver. So they're really leveraging the InterRAI results to help determine waiver placement. Again, they're using the InterRAI for service planning and for these budgets as well. Let's talk a little bit about our pilot study. So in Nebraska, again, we wanted to focus on the ID, or the intellectual disability tool, and the InterRAI, what we call the CHIME DD, stands for Child, Youth, Mental Health, and Developmental Disabilities. InterRAI is only standardized for kids ages 4 and above. So for kids who are younger than 4, there is still a slight gap. Nebraska is covering them through a number of different ways. But there is also an adolescent supplement that is attached to the CHIME DD tool. This is typically triggered for an adolescent who is showing some high aggressive needs, high behavioral health needs. Could also be used for a child younger than 13 if those needs are present. But again, typically recommended for 13 through 21. So for our pilot, we implemented the ID for everybody older than 22, and then for the CHIME DD, it was the age ranges that you see on the screen. Again, our objective was really to determine the appropriateness of the tool prior to making the change. Nebraska was very clear with stakeholders, with us, that they were not implementing the tool to cut budgets, to cut people from programs. This was all done for the purposes of demonstrating the appropriateness of the tool in Nebraska. In addition, while CMS does not dictate tools that states use for eligibility for level of care, they will ask questions. And one of those questions typically is the state trying to inadvertently cut people from programs by switching eligibility tools? To which I hope the answer is always no. But that is typically a question that they will ask. So by doing this really robust assessment, Nebraska could, and they did, talk to CMS. They provided them with our results, and it helps just move that kind of administrative approval process through once states are at that point of CMS. We also looked at the InterRAI tools, again, for waiver enrollment, which was completely new to the Nebraska space, and for service planning as well. For our population impact study, we were pretty primarily focused on eligibility. Again, that's mostly what CMS will ask questions about, but certainly we looked at service planning and all these other things. The way that this functioned is that the E&E and service coordination assessors, so service coordination, I failed to mention, would do the annual renewals for people already on the program. Historically, that process has since changed. E&E is doing everything, so initials and renewals. But during the pilot, we had E&E and service coordination complete these InterRAIs. The developmental indices or DIs and the ICAPs were actually submitted to us via an SFTP or Secure File Transfer Portal. We received the InterRAIs through something called the Qualtrics. It's kind of like an online survey type of deal. So we received some of these electronically. We received most of it through PDF. We had to do a number of different data collection pieces as well. So for everything that we received as a PDF, so those DIs and the ICAPs, our team actually manually entered them into a spreadsheet. It was not pleasant. I had a newborn. I was up at midnight doing all kinds of newborn things while data entering at the same time. But that went through a primary review and then ultimately a secondary review as well to make sure that the data was clean, appropriate, valid. We didn't have any data entry errors. We also had some automated data validation processes. We used Access quite a bit. We used Excel quite a bit. But we also had some manual, again, data validation reviews by our senior leadership team as well. This is just, again, kind of a little bit more about the process. This is pretty comprehensive and a little bit of what I just spoke about. So I'm going to go ahead and move on. This was our pilot summary. Again, I don't want these numbers to scare any of you in the room. We decided with Nebraska to do a 95.5 sample based off of their current kind of enrollment numbers. I will say that this unified sample changed quite a bit during the course of our pilot period. Initially, we were hoping to hit somewhere around 1,000 assessments. We ended up tweaking this for a number of reasons. We landed on 656. If anybody is doing math in the room, kudos to you, but I am not. But I will mention that we actually had 12 assessments that we couldn't determine whether or not it was an initial or a renewal because that information was missing when it was submitted by assessors. So these bar charts actually won't equal 656. This pilot period took about 5 months. That was very aggressive. We actually had planned for a 6-month pilot period, which again would have been very aggressive. We got started a little bit late, so we ultimately ended up having 5 months. We ended up training about 69 assessors who sit with the Division of Developmental Disabilities. We wanted to really make sure that this data sample was valid and it was kind of equitable across our regions. So we did it by the DD districts, which is why we took that map and talked a little bit about that at the beginning. I will mention that DD District 4 is Sarpy County, or I'm sorry, Douglas County? Sarpy County. Sarpy County. Sarpy has 191,000 people as of 2022 census. While it has kind of like the most amount of people in the district as far as just like one county, these other districts incorporate so many more counties that that's why their regional distribution is slightly higher. So again, that's a little bit of a nuance. Nebraska really cared about that, but I want to just point that out for everybody. This is ultimately, at the end of the day, what we cared about, our level of care impact. We looked at 456 adults, 200 children. We saw no negative impact to eligibility using the InterRAI. And I will also say that eligibility determinations were not made during this time period using the InterRAI. Staff were still, they were kind of co-assessing using the developmental index during this time period as well. So it was quite a heavy lift for them. We wouldn't necessarily have expected to see a large difference in eligibility between tools. In fact, if we had, that would have been concerning to us because typically DED level of care is pretty stagnant. Unlike maybe our passport waiver today, it's not atypical to see somebody losing eligibility because their condition has improved, whereas our DD programs, we don't typically see that. So our results were actually encouraging in that way. We'll talk a little bit about implementation, and I will say, if I had a whole another hour, I could drone on at you for a full hour and a half about implementation. I think we have learned a lot as Myers and Stauffer. I think Nebraska has learned a lot. We are continuing to learn a lot with each other. In fact, I was just on the phone with Nebraska yesterday about maybe making some tweaks to some of the outputs that are generated. So I will say this is not a stagnant process, this implementation process. And we'll touch on some of like the learning that has been occurring over the last several months, but this was essentially their timeline. So our contract with them started in May of 24, ultimately ended in June of this year. CMS did approve the waiver amendments to incorporate the InterRAI assessment as their eligibility tool. So that started as of July 1st. Some of the things that I would encourage any state to think about if they're thinking about InterRAI implementation, one of the big things first is to make sure that your state has an agreement with InterRAI. So InterRAI is a little bit funky in that you don't pay by assessment. It's really paying your case management vendor and their license to actually integrate InterRAI into their system. InterRAI organization, they are a collection of professors, really studious people who just want data and just want data to improve outcomes for people. So they're not in it to make money, which is great. But you do need to make sure that you have an agreement between InterRAI and your state to actually use the tools. You need to make sure that you have an agreement with the licensed vendor. And license there is very important. The vendor needs to be licensed with InterRAI to actually have the assessment or assessments sit in their system. One of the things we need to think a lot about are any assessment modifications. Again, we needed to do that in Nebraska. One of the things that we did actually amend a little bit was we took a question that existed in that adult tool or the ID tool and incorporated it into the Chime DD tool. There wasn't an equivalent, and we really wanted to make sure that eligibility wasn't lost as somebody transitioned to adulthood because of this one missing question. So that's something that you should always think about as well. Really, really key are assessor supports. And I'm not just talking training. Myers and Stauffer provides training to our state clients. We train on the InterRAI tool, but it goes beyond training. It's manuals, it's tip sheets, it's FAQs. We typically will do a weekly huddle with our state clients to make sure that assessors feel comfortable using it and are using it with, validity. The level of care, we call it a pseudocode. It's really an algorithm that sits in the case management system. But this level of care algorithm, if you were to use InterRAI for level of care decisions, is critical as well. Again, we want to make sure that we are not going to have people lose eligibility. So the identification of the items, how they're scored, and how they're fed into ultimately an output that says, yes, you're eligible or no, you don't, is critical. I would also add the importance of thinking about it for budgeting too. We'll talk a little bit more about budgeting in a few slides, InterRAI has a relatively simple way that you can think about budgets. But again, if you wanted to get super fancy with it, you could, and you would need to develop an algorithm for that. Lastly, these waiver enrollment decisions. This is something that Nebraska, I think, is learning a lot about, has heard a lot of chatter about. But again, if you're going to use InterRAI for that type of administrative requirement, I strongly would suggest that you guys consider what that looks like first. We sort of added that on during the pilot period. Nebraska had eventually identified that as a need. And so that wasn't necessarily something we had planned for initially. And I think that has caused a little bit of consternation from stakeholders. I think Nebraska has done a nice job being very transparent with stakeholders, but I think it created a lot of fear, maybe unnecessarily. This case mix index, this is what I was talking about as far as budgets. And I think this is a couple slides. I talked about the InterRAI agreements, so I'm going to go ahead and move on. I talked a little bit about assessor support, so I will go ahead and move on. Before we talk about CMIs, I do want to just mention here with the level of care algorithm that the way we did this, at least for Nebraska, the way we typically do it with our client states, is to actually take what's in regulation as far as the eligibility criteria and start matching it to what happens today using their assessment tools, and then crosswalking it to InterRAI, because we want to make sure we're not missing anything. We also want to make sure we're not inappropriately including anything. Some sort of crosswalk mechanism is really important there. And that's used to guide the algorithm build, essentially. We used SAS for this coding. Nebraska's contracted case management vendor is Therap. I don't know if anybody is familiar with Therap, but we've worked a lot with Therap over the last really couple years to make sure that this extensive testing took place before it went into production and actually was used to start generating eligibility determinations. This is what I wanted to hit on, knowing that my time is a little bit limited and I want to leave room for questions. This case mix system, it's essentially grouping people into similar resource utilization. So we have these case mix groups that are really groups of what we call a case mix index. And I think there's like 27 different CMIs. But basically a CMI score of 1 means that you cost, on average, you're an average cost to serve. And there's a bunch of math and statistics that goes behind it. I don't pretend to fully understand it. But InterRAI has done a lot of testing on the CMIs to make sure that they are valid for the population of the tool. And what I mean by that is a CMI that's generated by like the home care assessment that's used typically for older populations would not be valid for use with a developmental disability population. So they're very specific to the populations that we're talking about as far as the tool's kind of target audience. But the CMIs can be used to show how much on average it is to serve you. And again, so a score of 1 means you're about an average cost to serve. A score of 2 would mean that you cost 200% more than the average. We have used this in Nebraska, and we have aligned it with their 5 acuity tiers to basically put people into the appropriate budget. Again, the scoring was all done by InterRAI, so we didn't do this. This is a customized, or I'm sorry, this is a standard item that will produce on any InterRAI assessment. So the result essentially just spits out from the assessment items and how they're scored. But what we did, again, was align it to their acuity system. What we have found since post-implementation is that most people are staying in their budget range that they have had for many years. We have seen some movement up and down. And partially, it's because they weren't doing the ICAPs every year. So we know that somebody's needs could change easily over the course of 5 years, but because they weren't capturing it on the ICAP, we are seeing some people move to acuity levels up and down. Again, this has caused a lot of, I would say, tension in the stakeholder community, but I do think it's because this wasn't maybe as well communicated as it could have been. And again, largely a reflection that they weren't updating people's budgets yearly. So this isn't really an InterRAI issue, it's a bad practice issue, and I think Nebraska would actually agree with that assessment. The InterRAI elements just taken as on their own, the CMIs, scaled scores, caps, these are all used or could be used for waiver enrollment decisions. I won't go into kind of the nitty-gritty of how Nebraska is doing this, but we are looking at a number of items, a number of combination of things to inform waiver enrollment. The benefit is really kind of improved alignment between assessed needs and the waiver that's being offered. It really helps to use limited federal and state funds and funnel them to people whose needs are greater so that they can fund comprehensive DD slots at a higher rate than maybe they were previously able to because they were just putting everybody in that waiver regardless of need. And again, it aligns with this greater initiative that revolved around registry elimination. So some lessons learned. I think you, Nebraska, there needs to be some definitive decisions on day one about its use. How is it going to be used for administrative decisions like budgets? What is the appropriate age range and a tool to use? And we want to make sure, again, that we're thinking about it between settings. How is the tool going to be used to inform a residential placement versus somebody who wants to live on their own in their own apartment? You need time for collaboration with InterRAI as the organization and other entities like a case management vendor. InterRAI is very, very hard to get in touch with, particularly during the summer months when they all go on sabbatical and do research projects. So I would plan accordingly. Training and resource support is truly key. You need ongoing training and resource support on an ongoing basis. I think one of our faults that we are quickly learning is that on June 30th, our contract ended with DD. And that was it. We didn't have the availability or opportunity to really do post-implementation with them in a way that we should have done. Their assessors are still struggling a lot with appropriately answering questions. One of the things that just came up is there's an item that looks at if somebody has ever been institutionalized. There's a number of years. You basically put in the number of years somebody was institutionalized. You will code a 99 if it's unknown. But those assessors are inappropriately coding a 99 if they just don't have documentation. It's not that it's not known. It's just there's no documentation. Likely, if it's a kid, they've never been institutionalized, right? Or at least that would be the hope. But that 99 has downstream impacts that nobody realized until relatively recently, and it's impacting budgets. And so again, nobody knew this until a couple weeks ago. And just that need to have us in the room to help with IT vendors, to help with the policy work, is something that's really critical. And I would encourage you all to think about for post-implementation support. Transparency with all partners. Coming from Ohio, I know that you guys are very, very transparent with your partners, your participants, individuals, families, guardians, advocacy groups, but transparency is really key here. I think to some degree, Nebraska was a little bit afraid to share things before they were fully known or implemented. And I think that has done them a disservice. And now we're playing catch up a little bit with that. Lastly, and this probably should have been the first thing, I cannot stress enough the electronic system needs here. The state needs extensive testing in whatever system they're going to use to implement the InterRAI. And I would really encourage you to think about the outputs or what's generated from the InterRAI first, rather than the inputs. What items are going to be used to determine level of care. Those outputs will look different based off of the case management system. You need to likely have a vendor that can help deliver some customization with that. We are doing a number of different customized things with Nebraska, with Oregon, with Kentucky about their outputs. What do you want to see? Is it just strictly yes or no, you meet level of care eligibility? Is it that you meet the need for residential supports like a group home? Is it that you want to see what domains you met in as far as eligibility? Did you meet because you had a high need with self-care? That's totally up to the state to determine, but that does require a lot of technical coding. Again, you need some strong analytic support. I don't think it would be a surprise to anybody in Nebraska if they heard me say that their analytics a little bit lacking. So again, the things that I would expect maybe state staff to do at this point, tweaking of the algorithm is still with us, and we're happy to do it, but that is something that, again, I would encourage people to think about. And again, this clear framework for outputs, I really can't stress that enough. I think this is one of the biggest lessons learned that we have had as a firm, that Nebraska certainly has had. We're learning it along the way with Oregon and Kentucky as well. So it is really pretty critical because this will drive a lot of the decision making. And with that, with 10 minutes left, I will open it up for Q&A. Thank you.
All right, we got a question over with Monica. Oh, that was really loud.
I was just curious with the assessment, child versus adult, did you take into consideration school enrollment?
Not sure where that's coming from. That's child and adult.
Yeah, so I think not in the way you're meaning it to. Nebraska has an odd age of majority. It's actually 19, not 18. And so we needed to think a little bit about the cutoffs that we were going to use for the different assessments. The Chime DD assessment, you can actually cut off at the age of 18, but because of this transition age youth period, because of EPSDT requirements, we extended it through 21. We did not really engage the school system throughout our pilot period. As far as school enrollment, if somebody had graduated at the age of 18 instead of 21, they were assessed using the Chime DD because they just fell within our age range. So it was really more based on age range, not school enrollment, although that's something that certainly you could think about as you move forward in Ohio.
All right, last ones.
Two questions I have. Like she said about school. The thing is, how law says that the individual can stay in school till 22. People could be graduated from school, but then graduated from the local school district, but they go to college and they're trying to go for a degree. Does that mean they are in the child version or the adult version? Because they in the child version they have education, the adult version they do not. So I feel it needs to be considered and stuff. Also, does it assess any use of assistive tech, using remote support or assistive tech too?
Yep, great questions. It's good to see you, Christine. So yeah, your first question, the school enrollment thing, I think that's a great key there, right? Both assessments actually look at education, volunteer opportunities, voc, rehab, engagement. So there is actually a lot of crossover between the tools. Again, if you found something missing that was critical to think about for these kids who are graduating early, but maybe are being assessed using a child tool, you certainly could take a question from that adult tool, the ID, and place it in the Chime DD. Again, InterRAI gets a little bit, strange when you start tweaking the language in existing questions, but to carry over a question, if there was a need, you could certainly think about it. As far as assistive tech, remote supports, yes. Both InterRAI tools actually look at communication styles. And again, these informal supports as well. There are a number of questions within each section that kind of get at what do you have in place today? What maybe do you need to help communicate in a different way? So yeah, it does account for those items.
She said it does account. She feels like it does.
It does. Yeah.
Remote supports too, you'd say it might.
I don't know off the top of my head, but I mean, I think there is some variability in the technology questions, but there is tech incorporated into that. Yeah.
So there may be tech, but not as much remote, which is the thing where the department has to look at the whole thing and decide if they want to add any questions based on our needs here in Ohio. We have a we have lots. Monica, are you okay? There's a couple questions on the webinar chat that I just wanted to clear up. And again, this is the questions are, I think, are based to Ohio. So I don't know that they are appropriate for Jackie. I already lost it, but is the InterRAI also part of eligibility? I don't know if they're asking in Wisconsin.
So
I'm sorry, in Nebraska.
In Nebraska, it is part of eligibility.
Yeah.
I don't know that any final decisions have been made about its use in Ohio, so I can't really speak to that. But yeah, in Nebraska, they are using it for waiver eligibility.
Yeah, and there's been long-term discussion of level of care being incorporated, but not necessarily eligibility.
Yep.
For county board services. You got a question in the room?
We're saving it.
So Ohio specific? How many states has the InterRAI?
That's a great question. We are currently implementing the InterRAI in 3 states. I think Kansas is actually interested as well. We're not doing that work in Kansas. There are a number of other states that I have heard having interest. Most states are actually using the InterRAI home care assessment for their aged and disabled waivers. The use of the ID and the Chime DD are relatively new in the waiver space, is what I would say, but certainly gaining traction. I know Advancing States actually just did some work with InterRAI. I think they were really promoting its use. But yeah, this is kind of like a national trend that we're seeing, but mostly it's been used in the aged and disabled space thus far.
Okay.
You were talking earlier about how Nebraska was divided up into the different regions and referred to kind of like how our COGS are divided up.
Kinda, yeah.
My question is related to like how the assessors are structured in that. Are they under like an equivalent to what we have as COGS, or were they under the state? Like
they're all state staff. Yeah.
They were all
state staff. Yep. So they work in their different divisional offices, but they're all employees of the state of Nebraska.
So I have a follow-up to that.
Yep.
So you were talking about the agreements that need to be in place between InterRAI and the state.
Yes.
And where Ohio is looking at doing the COGS, does that mean that there will be agreements between InterRAI, the state, and the COGS for that?
I don't know that I can speak to that eloquently or informed enough. So I'm gonna actually pass you over to maybe OACB staff or state staff in the room. But I know for sure it would have to be with the state for sure.
Yep, always county boards and the state have been talking for many months about the role of the assessor and how that will come into play. Just as county boards have staff that do assessments today, county boards can decide how they're going to implement the assessor role for the InterRAI in the future. So we have been working with all 88 counties. Some counties are hiring their staff internally to have hired staff to do the assessments. Some there is kind of this idea that there is a limited number of assessors for Ohio. So similar to Nebraska, we're talking about 65 assessors for Ohio. But it'll look like either county board staff, they could be shared staff. So counties could be sharing assessors, or they could contract with the COG. So it's up to the county, and the look of the statewide view of the limited number of assessors to determine where that, how that was going to play for that particular county. So the answer is it varies by county. All the above.
There you go.
A couple things actually. To the one question was to the number, I guess, of evaluators. Do you just, I guess, not to speak on Ohio, but what you saw in Nebraska, do you have, I guess, an opinion on, I guess, because there's such a population disparity, right? So just the number I'm seeing in Nebraska sounds comparable to what the talks are for Ohio. Does that seem, how did that work in Nebraska, I guess, number wise? Like, did that seem like a good amount, or how did,
Yeah, I think we heard a lot of opinions about the number. Was it right? Was it not? The service coordinators and even the E&E staff were really dividing their day-to-day workload up. So it really was a challenge for them to do this concurrent assessment pilot period where they were administering maybe 3 tools plus the DD eligibility plus service planning. I would say, honestly, we probably needed more, but we just didn't really have the ability to get more at that time. We did a lot of work into trying to figure out the right number for training purposes for the pilot, but it really ultimately was kind of just a ballpark guess. What I will say is upon first use of the InterRAI, it can seem really overwhelming to assessors. It can be pretty lengthy in nature, but once you get used to the assessment, used to being able to move between modules and items, we note and we have anecdotal evidence that actually the process will move much quicker once people get familiar. So it very well could have been, we were working with a group of staff who had never done the InterRAI before. They were pretty overwhelmed with it. But I think looking back retrospectively, I think had we had more, that probably would have been maybe a better thing, would have eased some concern on their side.
And just one other thing too, that when you're talking about eligibility, I
Yep.
guess we're talking eligibility for like a waiver, right? Not
Yeah,
eligibility for like
so-
county board services, right? So
Right. So DD does have this kind of equivalent to county board services. It's just their DD services. They don't use it on a county kind of level in the same way we do here. But yeah, I'm sorry. For the pilot, we were just talking about waiver eligibility. So as far as I know, they're not using the InterRAI for DD eligibility, meaning non-waiver eligibility. Although certainly you could explore that. That was just not something that we did with them.
We only have time. Renee, I will give Renee, because she's done so much work on this group, a question, but it is 4:30. I do want to clarify, Jackie, in Nebraska, do they do the assessments yearly, annually, or every 3 years?
No, it should be annually.
So I think that's important when you look at those numbers. I kind of questioned the department about that too when I saw this, but we are, the plan in Ohio is to do the assessments once every 3 years, which is why we are starting out with a similar number. But when they looked at how many, they're doing them every year. So they are doing those, whatever, 9,000 every single year.
And I would say annually because they're using it for level of care, right? So level of care has to be redetermined annually. So that's largely why. Yeah.
Related question. I was going to ask you about the steady state. So they do it annually, not every 3 years. And it sounded like the assessors were doing other things, doing the pilot. Are they dedicated InterRAI assessors now in the steady state? And how many do they have?
That's a great question. And I mentioned this, I referenced it in the presentation. Since we did our pilot, all eligibility activities now sit within the E&E unit. So service coordination is no longer doing those renewal level of care assessments that they had previously been doing. E&E has continued to be understaffed as long as I've been with Myers and Stauffer. I wouldn't even venture to guess how many staff they have right now. I think it's somewhere between 10 and 20, but I think it depends on the day. So and they are still doing the DD eligibility determinations too, on top of waiver eligibility determinations. They have some staff that are dedicated to support what they call SRT in Nebraska. It's kind of like Medicaid eligibility functions. So they are doing a lot. And I would venture to guess that they are continually understaffed. In fact, there is an initiative coming out of the governor's office that is requiring the department to like catch up on assessments because they are so far behind. So again, I don't know the exact number today, but I know that they have struggled with staffing.
Yeah, and you guys will be hearing more about, obviously, there's a lot more information. And I know that this probably just made you have a lot of questions, which I warned you. Just remember, this was Nebraska's experience. Monica, are you trying to get me to? Oh, yeah,
Yes.
Naoka, I'll let you talk.
Okay, thank you. I really want to say, I think it's really important to remember that the way Nebraska is doing it is for Nebraska. And we have thought all of these things through in Ohio, I promise you. We are not intending to use this for level of care initially. And one of the primary reasons is because of the annual requirement. And so we are looking to stretch this out to do it over 3 years initially. And so I would not expect that that's going to change for that period of time. And part of that is so we have 3 years, right? But we do want to limit the number of assessments that you guys are going to have to do. So it is our goal to eventually make this do more things for you, right? The InterRAI. But we have a lot of people in Ohio. And so, but we do have to limit the number of assessors because the goal here, we have to have consistency. We have to have fewer people doing the assessments so that they're done the same. The training is limited, the number of people. And I think Jackie has spoken to why those things are really, really important and necessary. So we have thought all of this through, I promise you, and we're trying to roll this out in the best way possible so that we don't kind of make some of the same mistakes that have happened with the DDP. And, that's gone on way too long. And so we're trying to get this done correctly. So that's all I want to say.
Yes, and I will agree. And just know there has been ongoing conversations. Your superintendents are, if you're not a superintendent, we've been updating them on a regular basis. The group has been working tirelessly with the department, and they've been working very collaboratively. And we do have a plan for the assessors. We do have some tentative. Each county has told us what their plan is. So over the next few months, you'll be hearing a lot more about it. But as an SSA, your county will have a few people that you'll know that do these assessments, and then that will take off the DDP and the AAI eventually from your job. And you will get some amazing outputs is one of the really good things that we've seen from it of what the results were and might help you inform service authorization. So good things, scary things, I understand, but happy to talk with anybody and enjoy hospitality hour. And thank you, Jackie.